White Reflex Unraveled by Dr. Divya. Over to you.
Good morning, everybody. First of all, let me thank KSOS for giving us this opportunity to present this topic on pediatric potpourri. Excuse me. So today I will be discussing about the white reflex unraveled, congenital cataract and more. The white reflex is an ominous sign because it is not only a sight-threatening condition, but also at times it can become a life-threatening condition. So understanding the importance of this assessment of red reflex, the American Academy of Pediatrics has made mandatory to assess red reflex in infants and neonates as a routine practice. So what are the abnormalities that you see? A symmetric red reflex is what you always like, but you can also have a dimmer reflex, a white reflex, opacities in the media, as well as the Bruckner test, which is the deviated eye showing a brighter reflex. So what are the causes of this leukocoria? One is congenital cataract. You can also have this ominous retinoblastoma, Coats disease, coloboma of the choroid and the optic nerve head. You also have a group of retinal conditions: familial exudative vitreoretinopathy, persistent fetal vasculature, retinal detachment, ROP, toxocariasis. Today I will be focusing mainly on congenital cataract. The rest of the retinal conditions, a few of it will be described by Dr. Divya. So pediatric cataract, the incidence is about 3.6 per 10,000 per year, and the median prevalence is 1.03 per 10,000 children, and it accounts for about 15% of pediatric blindness, of which 27% are associated with ocular anomalies and 22% with systemic anomalies. What is the etiology? You can have the most common is the idiopathic cause, then maternal factors like torch infection, drugs, radiation, malnutrition, fetal factors like metabolic disorders, deficient oxygenation, birth trauma, and congenital anomalies. And also the hereditary factors account for 25%, of which 75% is autosomal dominant. Morphological types, it can present from total cataract to affecting any part of the lens. These are the pictures that are taken from the Rupal Trivedi textbook. You can see that it has got a very varied presentation. But the importance of morphology is that sometimes the morphology points to the underlying systemic pathology. For example, the spoke-like cataract would point to a Fabry's disease, macular and diabetes mellitus, multicolored flux in hypoparathyroidism, sunflower cataract in Wilson's, and thin disciform in Loeys syndrome. But not all cataracts should ring the alarm sign, because sometimes you get what is called as a visually insignificant cataract. Maybe when you have got a very good red reflex, less than 3 mm of the central lens opacity, when the fundus details are very clear, visual acuity better than 6/12, all those things you can have a conservative and a follow-up management. Now, how do you evaluate a pediatric cataract? You begin with a general examination, then you go to the investigations where you focus on torch, IgG, IgM, VDRL, then urine for reducing substances, urine for amino acids. And in complicated cases where you're having a doubt about the diagnosis, maybe you can do an examination under anesthesia for this leukocoria to identify the cause. But in routine cataract cases, axial length, keratometry, IOP, corneal diameter, all will be done along as the initial test that you do for the general anesthesia. Now let us see 3 cases. The first is a 3-year-old child with bilateral developmental cataract. You go by the routine clinical examination. What is more striking in this particular case is that there is a very high risk of amblyopia, because for 3 years, over the 3 years, he was having the stimulus deprivation. And post-surgery, there is always, as in any child, there is a risk of visual access or pacification. So what is the surgery that we do? We do a lens aspiration with primary posterior capsulorhexis and anterior vitrectomy, and intraocular lens implantation under general anesthesia. Now, IOL power calculation in children is a very challenging one, not only because they're very uncooperative, but even under general anesthesia, you may not be able to get the correct axis and the alignment. Then, since the eyeball is very small, you can have the errors very much exaggerated, and the post-op myopic shift also adds on to the problem. Usually, you use a handheld keratometer and a portable A-scan and the IOL formulas to identify the intraocular lens power. But what is important is that the child's eye is growing. So we tend to undercorrect the lens power that we are going to put for the child, because you want the child to grow into the power that you are planning to put. For example, for this 3-year-old child that we saw, If the intraocular lens power calculation gives you a 28, maybe you will undercorrect it by 4 and you put in a plus 24 diopters. The surgery is complicated because of the reduced scleral rigidity and corneal rigidity, more inflammation after surgery, develop reopacification of the visual axis, and there is always a risk of amblyopia. So one of the most crucial steps is the anterior capsulorhexis. I've taken this video of Dr. Ramesh Kekunia from CyberSci. So this pediatric capsule being very elastic, we have to stain it so that the elasticity is slightly reduced as well as the clarity is improved. And you can see how you have to pull it perpendicular to the direction that you want the rhexis to form, because otherwise it tends to run to the periphery. An equally important step is the posterior primary capsulorhexis. So this is mandatory because if you don't do a primary posterior capsulorhexis, there is 100% chance of visual axis opacification because of the lens epithelial cell growth. Not only that, you have to also do a anterior vitrectomy associated, because the anterior vitreous space can act as a scaffold for the lens epithelial cells to grow into that. So it is mandatory that less than 5-year-old you do a primary posterior capsulorhexis with anterior vitrectomy. 5 to 7 years maybe just a primary posterior capsulorhexis may do good. Now suturing, yes, there is no other option because there can be fish mouthing of the wound due to pure scleral rigidity. The child can rub the eyes. Post-op assessment of the shallowness of the chamber may be very difficult and you may have to go in for another GA. So considering all these factors, you must really suture. The post-op complications of increased inflammatory response, secondary glaucoma, visual axis opacification, IOL capture, suture-related complications all should be kept in mind. So you follow up with vision and refraction, intraocular pressure, ocular alignment, and you give the glasses. So for a 3-year-old, you will be giving a executive bifocals, whereas in 1 to 2 to 3 years, what you do is you do the refraction and add the near vision plus 3. Now this is a second case where it is a 3-month-old child with bilateral cataract. So the importance is that in such conditions, surgery should be done at 6 to 8 weeks to get the maximum visual outcome. And the surgery that is done is lens aspiration with primary posterior capsulorhexis plus anterior vitrectomy. And you follow up the child and then you give them glasses with some add for the near vision. Now this is the third case. It is a 6-month-old child with a unilateral cataract. When it is a unilateral cataract, ocular causes are more likely and the systemic conditions underlying are rare. So you have to watch for PHPV, posterior lenticonus, trauma, anterior segment dysgenesis, and other posterior segment pathology. The critical period for surgery would be in 4 to 6 weeks. Now comes a $1 million question: to place an IOA or not to place an intraocular lens. So the infant aphakia treatment trial was done to find a solution to this problem. So they took 114 children, they divided them into 2 groups. In one group, it was just lensectomy with contact lens and patching. In the other group, it was lens aspiration, PPC, anterior vitrectomy, and the primary intraocular lens implantation was done. They followed up them for 1 year and up to 5 years, where visual acuity, complications, post-op adverse effects, additional intraocular surgery, stereo acuity, glaucoma rate, and adherence to patching was studied. So what did they find? They found that at 4.5 years, there was no visual acuity benefit to intraocular lens implantation. But there was 1.5-fold increase in post-operative adverse effects and 3.5-fold increase in additional intraocular operations when an IOL is placed. So what is the take-home message? Maybe in less than 7 months, it is better to leave the eye aphakic and focus with contact lenses. IOL implantation is recommended after 1 year of age, and 7 months to 1 year, the decision can be individualized. So the take-home message is, for bilateral congenital cataract, the ideal time for surgery is 6 to 8 weeks of birth. Unilateral, it is 4 to 6 weeks of birth. Lens aspiration with primary posterior capsulorhexis and anterior vitrectomy is what we advocate, and IOL placement usually after 1 year of age. But what we need to keep in mind is that this cataract surgery is just the beginning of this very long journey. So we have to follow up the child for many, many years for a better visual outcome. Thank you all for the patient listening. Thank you so much.
Thank you, Divya. That was